Well, good afternoon, everybody. Welcome to this session. And my name is Hans-Pieter Snels. I work for DEBRICHEM Medical, and I'm proud to be here today for you guys and tell you a little bit about our product, DEBRICHEM. I will explain a bit about the product for you, and then I have Andrew Sharpe and Steven Jeffery joining me later on and telling you about their experiences with our product in their clinics. And as you can see on the screen, Steven works with Pioneer Wound Clinic and is a consultant in burn and plastic surgery. And Andrew is a podiatrist, advanced podiatrist in the Salford region. And we're talking today about DEBRICHEM. And DEBRICHEM is a chemical debridement agent. It's developed in the Netherlands. That's where I'm from. Maybe you can hear it about my accent. And it's intended for non-surgical debridement of non-surgical infected wounds. And what does that actually mean? Well, basically any infected wound that you would see, chronic wound that comes into clinic, you can treat with DEBRICHEM. And the important thing to understand is that it's a one-off treatment of 60 seconds. So DEBRICHEM is a chemical debridement that uses 60 seconds to get rid of any infected material in the wound bed area. And with this video, we see Debbie from the Pioneer Wound Clinic. She will show you how to do a session with DEBRICHEM. So basically, you prepare your work area as you would normally do with a dressing change. And you would prepare your patient as well. So make sure that you got all your materials ready, that you got your gauzes and everything available. Make sure that you protect yourself, of course, for anything that's nasty, because these wounds can be very nasty. We have here a venous leg also that was compressed. And then you, of course, take the dressing off, make sure that you clean the wound bed area. And after cleaning, you can apply, for example, an EMLA cream because it's a debridement, and debridement can have a bit of a pain sensation compared to it. So also with the Sharpe debridement, you might want to use some painkiller. DEBRICHEM also has a pain sensation that is similar to the level of a Sharpe debridement. So after the cleaning, here Debbie puts on an EMLA cream, you leave it on for 20 minutes, and then taking off the cream. We speed up to 20 minutes, otherwise it would be a very long presentation. And then you take the bottle of DEBRICHEM, and as you can see, it's a very tiny bottle, but it's a liquid gel that comes out of it, and then you put it directly onto the wound bed. And what it's important to see here, what Debbie is doing as well, is that she covers the peri-wound area. And it's debriding the wound bed by, and I will explain in the next video how that works, by debriding the wound bed chemically with DEBRICHEM. And you can see a significant change of the wound bed as well. So now she rinses it off with saline. You can see the wound bed is changed. And for me, this is normal. But for you, I can expect that this might be a little bit of a shock to see this after 1 minute. But here you can see now a full clean wound bed. That is no biofilm, no infection anywhere left in this wound bed. And from here, you have debrided your wound bed. And you just cover it with any dressing that you find suitable for that patient for those parameters. And then the patient can go home. And eventually that desiccated plaque, what you saw, because DEBRICHEM will dehydrate the wound bed in that 1 minute, it will slough off in the coming weeks with every dressing change. So how does that actually work? I have an animated video here on how does DEBRICHEM work. So the mode of action, DEBRICHEM is a chemical debridement by capturing water molecules, dehydrating. So you have these infections in the wound bed, and when there is a bacteria, it will develop into a biofilm. And the biofilm is then most of the time this cause of this infection. A biofilm has a lot of water content in itself. So there's sugars and proteins in the biofilm that form the extracellular matrix, but there's also a lot of water. Up to 95% of the biofilm is water, next to the bacteria and all that sugars and proteins. So keeping in mind that it's dehydrating the wound bed, DEBRICHEM is focusing really on that biofilm infected material and dehydrating that aspect in the 1 minute. And it's doing that in 1 minute, so you can assume, you can think that it's a lot of power that goes in there to kill off all the bacteria, because that's what happens. It eradicates the entire biofilm in 1 minute. And this energy that is released by DEBRICHEM capturing these water molecules also causes these proteins to break down and proteins to unfold and losing their function in their structures, and therefore also the proteins that cause the biofilm formation and so on. So in this frame you see that the DEBRICHEM is going into the biofilm, capturing the water molecules. You see the pling going on, that's the energy release in the wound bed. And as I said, it's breaking down these bonds and structures of the molecules and the proteins. And that is actually what is causing that color change that you saw in the previous video after the application. So for me, that's what I said, it's normal to see that it changes into a dried out, darkened state after the 1 minute. So you create a hyperosmotic reaction, basically drying out these environments for these bacteria and leaving these bacteria in a crooked state like that, making them vulnerable as well for that energy release and breaking down the membrane proteins and so on and so on and so on. So it's a whole cascade of aspects of what's going on there. And it's a lot of information on the mode of action, but basically to understand that it's dehydrating the wound bed in 1 minute so significantly, so rapidly, to get rid of all the biofilm which is in there. And then you see the animated wound turning a little bit darker. And then now, Andrew will tell you a bit about his own experiences with DEBRICHEM in his clinic in Salford. Yeah. Thank you.
Thank you, guys. Yeah, so I'm Andrew Sharpe. As Hans-Pieter's talked about, I'm a podiatrist based in Salford, up in Greater Manchester. So why was Salford and DEBRICHEM kind of partnership to look at these pathways? So if you're at the first meeting this morning with Naz Ahmed, we are one of the first Martian sites in terms of, from a Mars point of view, looking at our amputation reduction. So our lower limb multidisciplinary service is a team of teams across kind of podiatry, diabetes, vascular, orthopedic, microbiology, radiology, tissue viability and orthotics. So this was where we kind of pitched it out first. It was within our multidisciplinary service that we first looked at DEBRICHEM and our pathways for using it. And as an organisation, or as a team, we've been referencing the Lower Limb National Wound Care Strategy Programme. The great thing for us is it's not a diabetic specific. Often when we come from podiatry, we'll talk about the diabetic foot ulcers, but we're not diabetic specific in the work we do. And as you'll have learned from Naz's session this morning, we've seen a 6-year reduction of all-cause amputations in Salford. And we're fortunate to have an acute integrated care acute and community integrated care organisation, so the MDT can pass across. So that's kind of where we started with when DEBRICHEM approached us as to why we could potentially offer some insight. So when we look at change and bringing about new products to market that are something different to the regular kind of wound products, it's thinking about how we change, recognising the appropriate intervention. And what we wanted to know is that we're not necessarily being wasteful or overusing. If we can improve our time efficiency, free up patients to have less contact with hospitals and use our resources better, then it overall has a better impact for our patients. And we're hoping we can reduce our wound care burden, so we're all becoming more and more aware of the work by Julian Guest about the wound care burden, and we're seeing that increase. I think at the last conference I saw him speak, he's actually talked that these increases are real and are happening. So we need to do more with less. We've got less staff, more patients, more time pressures. We're still feeling some of the COVID impacts with our elective surgeries, and it's how we can reduce the burden of lower limb ulcers whilst maintaining or ideally improving on our wound outcomes. So I'm just going to present a couple of case studies really from our practice. So we start with this lady who had a venous leg ulcer of coming up to 3 years, 2¾ years, 2 years, 9 months. The venous leg ulcers on the left. And the biggest deal for this lady was she was working, I think she worked in Tesco, and she was on her feet a lot, and she was getting a tremendous amount of pain with her wound. The issue we had in her adjunct therapies like compression therapy and things, she just wasn't tolerating because of the pain levels that she was experiencing. So we start with a wound of around about 12 by 6 centimetres, which is around a wound area of 72 centimetres squared that was too painful for compression. After 3 weeks, so it's like Hans-Pieter talked about, it's just one application of 60 minutes with the Emla cream first. She did find it painful as we did it because she had quite a sensitive wound, and it's not without pain. The Emla cream did do a lot to try and reduce that down. What she did talk about, so unfortunately we didn't get a picture at day 7, but what she did talk about the next time we saw her was actually she went for her normal pain relief on day 1 of having used the DEBRICHEM, and she found she didn't actually need her pain relief to the same degree. So she just said she sort of almost automatically reached to get her painkillers in the morning, and her pain had gone. So she went from a pain scale of 10 in the wound to a pain scale of 0. I'm not necessarily saying you'll see this every time, but this certainly happened for this lady. The other patients we saw were actually neuropathic, so it wasn't necessarily captured so well for those guys. So we've got a wound area reduction of about 23% within the 3-week mark, and she could go back into a reduced compression now because her pain had improved. By day 49, my maths isn't quick enough, 7 weeks, we're looking at around about 50% reduction. So considering we've had the wound for nearly 3 years, we're really quite pleased at how well it progressed. And then day 64, we've seen a wound area reduction of 86%, and she went back from coming into the multidisciplinary foot care service. She was back into a regular compression care now, and she went back to community services. So I haven't actually got the closed picture, but she did go on to heal, thankfully. So we'd failed in numerous other therapies. We tried things like negative pressure for this lady, and she didn't tolerate that. Tried topical hemoglobin, and the compression therapy just wasn't working for her because of her pain levels. The big thing for us that stood out was the pain went from a 10 out of 10 down to a 0 out of 10. She did say it started to creep back up over time, but it never got back to the severe levels, and she was still able to maintain compression therapy. And she was very positive about the experience. We did want a video, but she's quite a shy, introverted lady who really wasn't keen to get on camera to talk about it. But she did give us permission to use her words. She said, I woke up the day after treatment and reached for my pain relief and realised I didn't need it. It's been amazing, and I feel I've got a part of my life back, which was great to hear from a clinician point of view. So our next patient is a diabetic gentleman who's had this wound for 1 year, 3 months at the point we introduced DEBRICHEM. Diabetic foot ulcer, size is 2.2 by 1.8 if that's not overly clear, which is around about 3.1 centimetres. We had a normal range ABPI, and as you can see, we're unable to gain a good toe pressure. I think he's only got his 4th and 5th toe left on that picture. So we actually saw a small wound increase within the first 2 weeks. We went from 3.1 to 3.9 centimetres squared. But by day 35, we've seen a wound area decrease. I thought I calculated, apologies, I'm not. We were about 0.75 centimetres, so we saw quite a significant decrease over time eventually. And by day 56, we'd seen about a 45% reduction. We haven't quite gone on to healing for this guy. We saw improvement. We didn't get any infections occurring during the time period that we were using this evaluation within the 56 days. But what we did go on to discover was actually diabetic foot ulcer with normal ABPI and failing to respond. There was an element of ischemia that we weren't aware of at the start of the evaluation, but just because this almost helped us in our diagnostic, if you will, that We have really thrown everything at this. Again, similar to the previous lady, we tried things like negative pressure and topical oxygen therapy, and nothing was really shifting it. So this was almost like the last crack at the whip to see what would happen for him. And on the basis that we still weren't seeing improvement, it gave us kind of a good indication, despite clinically what looked like good readings, that we needed some further investigations. And he went on to have a CT angiogram with an angioplasty. Even following that, unfortunately, the gentleman's still not healed. He's suffering really with the adverse effects of mental health with this wound care as well, which hopefully if you come later on to see my talk, you'll learn a little bit more about the mental health impacts with wounds. Little plug in there for myself. At day 0, we saw this gentleman who's relatively young, type 1 diabetes, and he had an active Charcot deformity, which he had metal work. He initially wanted the Charcot pinning once it had settled down, but then it became quite painful, and he managed to convince the orthopaedic team to take the metal work back out. He was an inpatient because of an active infection, and he'd been in for debridement of the wound bed. So the actual centre bit, the darker area, goes to around about 1 centimetre of depth, but there's no underlying structures that we can feel. So within 4 days we saw quite a big improvement, but the measurements weren't captured, unfortunately. Hopefully the visualisation of day 4 and day 21 will show us. We were seeing this team in combination with the plastics team as well. Often when plastics was seeing it, he would decline us taking the dressing down to take a picture. And then it went on to complete healing, I think within a 6-month period. But of course, no one takes pictures when they heal. And then our third case study really was, we saw an excellent response for a neuropathic diabetic foot ulcer, which had some metal were removed and really quite concerning. At the point of day 0, he'd only just come in with an active infection. So really we wouldn't necessarily expect to see such a good improvement within the 4-day window of the depth and everything coming down and the infection coming under control so well. I know he was on IV antibiotics as well, but I think from a topical point of view, it certainly played its role. So we saw an excellent response for our pure neuropath patient, and it supported our antimicrobial plan. It was quick and effective debridement, bedside debridement done, and we went on to complete healing, I should say 16 weeks, I think we said, 14 weeks, sorry, not 12. So the initiating change is introducing a new product into our day-to-day practice. Becomes one of confidence to start with. It's a relatively simple product to use, but I think really because when you hear the effects of it being a chemical and it being a rapid debridement and all the elements that go with it, there's a little bit of a reluctance that you don't want to make people worse. So we kept it within a small team within the MDF setting to demonstrate the ease of application, and then thought about how we could use it in the community. It was a straightforward process to use, but I appreciate that whenever we introduce these things, everyone needs to be cautious in their own way. Making people aware of the pathway and the fact that we've got these products available. It currently still sits predominantly with our specialist areas, but I think a lot of that now is to do with we're the guys that probably know about the products. Our generalist nurses don't necessarily know of the product, which is partly a failing down to us, but it's being able to have those conversations and get out to see people to talk about the products, which we do in work with the companies to try and encourage the kind of the wider spread within our own teams. And then it's events like this where we can spread the message as well. And we continue to monitor our outcomes, and we'll still keep using to see how well and effective this works for our patient group. The cost impact we've not properly measured within our own organisation, but we certainly know from a 2 years, 9 months onto a pathway to healing that healed, and the cost of inpatient care is really more significant than the cost of a product sometimes. So our intervention teams, podiatry, tissue viability and multidisciplinary services and plastic and orthopaedic surgeons use these, but we have, in fact, only last week one of my colleagues Did this out in the community for a bedbound patient who's had a lateral malleolus wound now for I think around about 3 years, that even despite best pressure care and everything just doesn't seem to be responding. He's a paraplegic patient which was caused by surgery, so he's dead against going back to the hospital to have a surgical discussion. So it's about using this as a toolkit that we have in our bag and picking the right patients for this to work. It's about our confidence, our competence and our experience that hopefully helps us getting more use with it. The balancing measures is the patient experience, the cost of the dressing use, cost of the product use, sorry, not dressing use. Staff learning needs, the education that goes with it, the review of the actions, the review of actions taken. It's an onward referral, and we've got to think about whether that impacts positively or negatively on our referral pathways. And hopefully we see a reduction in our incidence of infection over time with using it. So we saw an improvement in the non-ischemic, truly neuropathic and venous legs. We definitely saw a number of positive experiences. I picked 3 out there for you today. Is still being aware that it isn't a magic bullet. When you've got an underlying condition such as ischemia, this isn't necessarily the cure-all kind of products, but it's in the right situation, it can have a really positive effect, and hopefully that's what the case studies showed for you. And hopefully we may prevent deterioration in our ischemic foot ulcers, keep them in a steady state until we can get a surgical opinion. Might be part and parcel of our pathway going forward when we use it in the community. But it's a BioNDT discussion, it's not using these products in isolation. Thank you. I'm going to hand you over to Steve Jeffery, who's a consultant burns and plastic surgeon.
Thank you. I'm from the Pioneer Wound Clinics, which is the UK's biggest private wound care provider. And I teach on a lot of debridement courses and a lot of sort of burns and plastics courses generally. And this is one of my slides I always start with when I'm teaching on debridement. And debridement is actually absolutely the key to all trauma and burns and plastic surgery for wounds. What does the term debridement mean? Okay, so we've got to get rid of all that kind of stuff. And then the next slide, and you'll see this in all the textbooks, I'm sure. What are the methods of debridement? And you see that there's a great big list there. And we always start out confidently with the ones at the top of the list, knife and fork, etc. And then mechanical, where you've got, so most of these I can give examples of. So your mechanical, you've got your DebriSoft, etc. Autolytic, people go, autolytic, what does that mean? Basically, you know what autolytic means, let the body do it itself, keep it moist and the body will do it itself, sort of lazy man's debridement really. Biological and enzymatic, well biological, you've got your maggots, etc. Although technically speaking, they are enzymatic because that's how it works. And also there's some other enzymatic ones in there. You've got your various collagenases, etc. for burns. But then there was always one at the bottom, chemical, and I sort of glossed over that one. And next slide, please. But we've got a chemical debrider now, as you've been hearing. So it's great that we've got another tool for our toolbox, because we all use all these kind of things every day. Okay, maggots maybe not so much, and it depends on your practice, but we've got all these tools that we choose. We see a patient, we see a wound, and we reach into our tool bag and we choose the appropriate tool for that job. And now our tool bag has just got a bit bigger, which is great, because there were some patients where we were trying to use a hammer to drive in a screw, So it's all about using the right tool for the right job. And often we want to do things quickly because we're in a hurry, we have a lot of patients to see, etc. So for me, for getting rid of tough tissue, the quickest way for me is the knife, because I can chop it off, For tissue that likes to move out of the way, like muscle and fat, I like to use the scissors because it sort of grips as it cuts, and the fat will move if you use a knife on fat, it'll sort of move out of the way. Whereas if you use scissors on it, it can't move out of the way because it grips. But then there's this loose sort of adventitial tissue. That's stuff that we can't really, what we like to do when we're debriding, don't we? With our left hand, we get a pair of forceps, so we grab the tissue nice and firm. And then with our right hand, rather than a scissors, knife, or whatever, we cut it off. That's what we like to do. But there's that tissue that doesn't really want to pick up. Can't really pick it up. And that's where Versajet is very useful for those who get the Versajet, who's access to the Versajet. It's very good at that, and it sucks up as it hoovers. But this is also where DEBRICHEM comes into its own, because obviously not everyone is going to have access to a Versajet, particularly in the outpatient setting, because of the big box. So, 3 speakers here. We've all going to be a little bit of overlap, unfortunately. You've all seen this stuff by now. It comes in a bottle this size. So you have to carry it around like that. No, actually, the bottle's this size. So don't be disappointed when you get your little bottle like that. And you shake it up, kind of red, oily liquid, and it smells of beetroot. They swear to me, there's no beetroot in there. But I recognize beetroot when I smell it. So, Hans-Pieter, what do you say about that? And then, so yeah, it's a single application. So you put it on once, and then you get the benefit for the next number of weeks, etc. And you've also already seen how it works on the biofilm. How does it actually work? It's a very, very strong acid. So the pKa, for those of you who are into chemistry, is actually a minus. pKa means it's a very strong acid. So it actually doesn't really, can't really work as an acid unless it's in water. So it loves water, and it will suck the water out of anything. And that's how it acts on the biofilm. And as you've been hearing, the biofilm is mostly water. And it is painful. So that's why you've got to put on EMLA. Okay? So I don't know how many of you are used to this. So this will be new to some of you. But it is, it is licensed for use. There are other local anesthetics available, but this is the only one that, as far as I'm aware at the moment, is licensed for this use. You can inject local anesthetic if you want, and I'm happy to do that, but most people aren't, and it also takes a little bit of time, etc. And it also takes a little bit of time to soak in. So, you could, if you have got multiple rooms available, we have in Bio, we've got multiple rooms, so you can put it on, you can go to the next patient, and then you can leave it longer than that, and it's not going to do any harm. You do the next patient, juggle things around. So basically, biofilm, it will absolutely sterilize your wound for you, okay? Albeit temporarily, it's not going to stay sterile forever, okay? This is not going to sterilize your wound forever. Eventually, the outside world, and it's going to create a tough eschar on there, which is a physical barrier. But eventually, the bacteria will get back in there. You're going to put a dressing on. Bacteria work their way in. But in the meantime, you have allowed the healing to perhaps restart. Because we're all very good at the overt signs of infection. I think those overt ones are good, and if each one of us saw a patient that had all that kind of stuff, we would say, oh, that patient's infected. But it's the covert signs that are harder, and that is why if we had a patient in here that had some of these signs, some of us would say, oh, that's infected, someone would say that isn't infected. And then, of course, there's all different things. Is it infected? Is it just, heavily colonized? Is it locally, is it being invasive, etc.? But we've all seen this. Lots of the granulation tissue that's not right. It's not that beefy red granulation tissue. It's the more jelly-like granulation tissue that there's. When I was training, we said there was healthy granulation tissue and unhealthy granulation tissue, and then all these other things, pocketing. So these are softer signs. Increasing exudate, and this are the things that we as clinicians have to be on the lookout for, because someone less experienced might not pick up on some of these things because they're not barn door, redness, swelling, etc. So what we did, just over a year ago, we did a service evaluation for DEBRICHEM, looking at 21 consecutive patients over a 2-week period. As you can see, the usual customers tending towards being the elderly. In this case, more males, a little bit overweight, some smokers, but lots and lots of comorbidities. So, and the usual comorbidities. These are all the kinds of people that I'm sure you recognize coming to any leg clinic. For the study, these patients had to have no sign of reduction of wound healing for at least 2 weeks, and had to show some signs of infection. So, those signs that we talked about earlier. And as you can see, most of them were venous leg ulcers. And the average length of time present was 22 months. So we looked at various things. First of all, looked at what happens to the slough and the necrotic tissue. So the necrotic tissue, the red, the slough, and the exudate. You can see this, although it doesn't initially increase the amount of necrotic tissue because you're turning that biofilm into necrotic tissue essentially, and it turns this brown color, as you saw in the video, in front of your eyes. Exudate, we will come to that, but I think you get an increase in the granulation tissue. This is just that graph put another way, and you can see that as the slough goes down, the granulation tissue replaces it. So it's replacing the slough with the granulation tissue. And these wounds that had been static for, on average, 22 months, do start to now decrease in size. And if you map that as a percentage area reduction, you can see that a percentage area reduction per day, you can see that there's the maximal sort of acceleration in wound healing is around between weeks 2 and 3, and then you tend to go back to the same rate that you had before. And I've been saying, and I don't think the company will particularly endorse this, but you might want to, at this point, if it's starting to tail off, you might want to think about a second application. Because you're not going to get rid of the bacteria forever. You are sterilizing it, and then the bacteria may come back. And this is looking at the exudate. You can see there's not really much change in the exudate patterns. But what I was surprised by too was the pain, because having been told about this product, and it's very painful to apply, etc., I was thinking, oh God, this is going to be great. The patient's going to scream in agony. But that wasn't the case, actually. So if you look at the base, this is the baseline pain score. This is the pain that they have before you do the dressing change. You can see a lot of them are in pain anyway, and but towards at the end, less of them are in pain. The pain is less. And I had a chap, just like we just heard, who was on 8 Tylenol a day for not Tylenol. What's the opiates a day for because of the pain, and it was one of these that sort of winced every time you looked at him, and as you were taking the dressing off. And next time I saw him, he said he hadn't had any pain since the procedure, and that he stopped taking his painkillers. So I don't quite know why that is. Is it that bacteria that's causing the pain? Or is it something else? So yeah, be surprised. There are some patients, particularly the ones who are very painful, get a lot of benefit from it. So this is just looking at another way. So these are the pain scores. You can see out of 10, so they're not high. They're in the low down in the pain scores. And so that's a general pain there. And then during the cleaning of the wound, because you clean it before you put the DEBRICHEM on, that was the pain there. Again, not huge. And then after the DEBRICHEM, we're still talking, 3 and 4. So it is bearable because you get a lot of benefit from it. Then overall feeling about, we asked the patients what they felt about the DEBRICHEM compared with the previous treatments they've been having, and a lot of them thought it was a significant better. And then we asked the clinician, likewise, and the clinician, I should say clinician, not physician, because it was mostly nurses that did this, but were very pleasantly surprised. So I'm just going to go through a few cases now. So this is a typical patient that I'm sure that you've seen quite a lot. This patient had been stalled for 3 years now, heavily colonized, and he didn't like you curate. We tried to curate the wounds every time, but he didn't like you doing this. It was too painful. And you can. They say that you can't see biofilm. You can't see biofilm, but we can all look at that and we can say there's lots of bacteria there, aren't there? And how are you going to debride this then? What would you do if this was your patient now, turned up to your clinic? What are you going to do? Are you going to debride it? If so, what are you going to debride it with? Any volunteers? Anyone not going to debride it? Okay, so you could do it. You could do a mechanical dip. You could do a DEBRICHEM or similar. Yeah, you might get something away. Yeah. Curette. Yeah, curette very, very painful. Scalpel likewise very painful. So what we did do is we put some Emlet on, and then put some DEBRICHEM on, and that's the appearance that you get straight away. That sort of brown, tough eschar. So we know it's dead underneath. The bacteria are dead underneath, but on the top, it is a barrier to further infection. Then what happens over the next week or so is that stuffy layer starts coming off. I haven't tried this yet, but I would like to. I've heard that putting the DEBRICHEM on and then immediate NPWT would be a good idea. And I've resisted it until now, but I'm thinking maybe I should try it. And it sort of supercharges the granulation tissue. So then that granulation, that hard eschar softens and comes off, and now you're left with a much healthier looking wound, aren't you? Much healthier looking wound. It's got the chance to go on and heal now. So you can see then there's some pockets of epithelium trying to, once you get rid of the bacteria, wounds should heal. What is stopping them often is the bacteria, giving them a chance to heal. Yeah, this patient was a drug addict, and they were on something to a blood thinner anticoagulant because of all the DVTs they kept on having. Hard to debride the wounds. Nobody likes doing Sharpe debridement on a HIV, hepatitis C positive patient anyway. I mean, it shouldn't affect how we manage our patients, but it does. The reality of it is people with hepatitis C and HIV positive get less Sharpe debridement than those who don't. In this case, you can seal the wound there, and then allow it to heal up like that. And again, chap with long-standing wounds which were very difficult to debride. Yeah, the curette just isn't going to work there, I don't think. So it's hard for me because I'm a surgeon. I think I'm the best debrider ever. Right? So when this company came to me and said, "Oh, we've got this product," I was a bit like, "Yeah, right. You're trying to tell me about debridement, yeah, right." But I have to admit, I could not do as good a job of this in a shorter time as the DEBRICHEM can. Can you see it's just it gets rid of the bacteria, allows the body to heal itself. So, I've had to eat humble pie and say surgery isn't perhaps the cure for everything. And sometimes we need an adjunct such as this. So you can see very, very angry looking, and it's angry because of the bacteria there. I'm pretty sure that's what's causing it to be so inflamed on the left, but whereas on the right now, the bacterial load is much reduced and it gives it a chance to heal. Likewise, I could have easily taken a curette to this, but my time is expensive, your time is expensive. Okay, the product doesn't come free, but it's cheaper than our time to get from a wound from this situation into this kind of situation. And it's a single application, so you get one application on a wound like this, with you see those purplish edges. I was thinking, oh, is this pyoderma or something like this? Anyway, we went for it, and you can see that we were glad we did. Because when you debride something that you think might be pyoderma, often it gets bigger. But not, it appears, if you're using DEBRICHEM. So, in summary, we've got a new tool. It's not for every wound. Most wounds won't need this, but there are certain wounds you will all see as clinicians, unless you're in a very, very special clinic that doesn't get any infections or patients with comorbidities, etc., that it will be useful for you, and I think that you should try it because it will be quicker and it's more effective than a human can be.